Hello everyone, this is Dr. Madhusudan Rao. On the program, I teach medical students. The topic of today's lesson is cerebellar stroke. Cerebellum is the structure that is responsible for the smooth execution of the voluntary act. It is located in the posterior cranial fossa, below the occipital lobe and behind the pons and medulla. And cerebellar stroke is the cerebrovascular accident of posterior cranial fossa, involving either the posterior inferior cerebellar artery, anterior inferior cerebellar artery, or superior cerebellar arteries. These are the branches of the basilar artery that supply the cerebellum. We are going to touch this topic under etiology of cerebellar stroke, clinical presentation, and the treatment. Let us go about it. Cerebellar stroke is same as any other cerebrovascular event. It is a severe of the posterior cranial fossa, affecting the structures of the cerebellum. And the clinical presentation depends upon the area that is affected and determined by the margins of the infarct. Structures that are located in the area of infarct. Okay. It could be ischemic or hemorrhagic, as a matter of fact, of any other cerebrovascular accidents. Ischemic stroke is secondary to the obstruction to the blood flow, resulting to the deprivation of the oxygen supply to the tissue, thereby resulting in infarct. This could be due to atherosclerosis of the large vessels or embolic phenomena obstructing the small vessels. Right? Hemorrhagic stroke results in the damage to the tissues and also complicates raised intracranial pressure, which again compromises the perfusion of the brain tissue. Well, cerebellar stroke accounts for about 2 to 4% of the total stroke events. Etiology. It could be ischemic stroke, secondary to thrombotic, thromboembolic, or embolic phenomena. Or it could be a hemorrhagic stroke, secondary to bleeding, complicating hypertension, arterial dissection, antiplatelet therapy, bleeding from the tumors. Okay. Well, it could be subdural or it could be secondary to trauma. Coming to pathophysiology, we relate the various symptomatology of vascular lesions and their presentation. This picture shows the cerebellum and its arterial supply. It is supplied by the posterior inferior cerebellar artery, anterior inferior cerebellar artery, and superior cerebellar artery. These are the branches of the basilar artery. Posterior inferior cerebellar artery lesion presents as headache most commonly, less commonly as vomiting, vertigo, horizontal ipsilateral nystagmus, and truncal ataxia. Lesion of the anterior inferior cerebellar artery presents as dysmetria, Horner syndrome because of the involvement of the sympathetic fibers, ipsilateral facial palsy because involvement of the fibers exiting from the pontomedullary junction, ipsilateral hearing loss because of the involvement of the vestibulocochlear nerve, and contralateral loss of pain and temperature because of the involvement of lateral spinothalamic nerve. Well, lesion involving the posterior cerebellar artery results in more severe ataxia, dysarthria, okay, nystagmus with less headache, vertigo, and vomiting. Okay, nystagmus is more severe when compared to headache, vertigo, and vomiting when the posterior cerebellar artery is involved. Raised intracranial pressure is the most devastating complication of the uh, cerebellar stroke, because reactive cerebral edema results in the signs of raised intracranial tension, because cerebellum is located in a limited space, okay, with bony boundaries like fetal spot of the temporal bone, occipital bone, okay, and anteriorly there is the pons, medulla, okay. There could be compression on the fourth ventricle and compression on the aqueductus CDS, and there could be pressure on the lateral ventricles, okay. With the raising pressure in the posterior cranial fossa, there could be displacement of the structures upwards as well as downwards. When there is a pressure, upward pressure results in the compression of the lateral ventricles, and pressure anteriorly results in the pressure obstruction on the fourth ventricle. Okay, if there is increasing pressure pushing the structures downwards, results in devastating cerebellar tonsillar herniation. Okay, cerebellum is located in the limited posterior cranial fossa. The space is very much restricted. There is compression over the fourth ventricle, the aqueductus CVS, okay, pressure over the tentorium, resulting in the tentorial herniation. Downward pressures result in the devastating cerebellar tonsillar herniation. This picture shows the stroke at various locations and their manifestations. Cerebellar stroke presents with the difficulty in controlling fine motor movements, okay, in coordination. Clinical presentation. Clinical presentation of the cerebellar stroke is mainly by non-specific features, which may resemble any medical disorder. Symptoms occurring while walking are attributed to cerebral lesion. The rest could be due to benign paroxysmal vertigo, vasovagal syncope, or arrhythmias, which start within seconds or minutes. Those which start in minutes or hours may be due to hypoglycemia, migraine, or psychological conditions, which start in hours or days, could be labyrinthitis, are triggered by loud sounds. It could be due to peripheral inner ear disturbances. But those occur while walking, they are more specific for cerebellar lesions. Dizziness is the most common presentation of cerebellar stroke, which occurs in 75% of the patients. Postural imbalance is next to that, occurring in 25% of the patients. And there is weakness, ataxia, nausea, and vomiting. More severe symptoms include limb ataxia, diplopia, nystagmus, and dysarthria. And remember, the manifestations are on the side of the lesion. That is, ipsilateral findings are the classical findings of the cerebellar stroke when compared to the lesions of the cerebral cortex, where we get the contralateral manifestations. Lethargy, deepening coma, and cardiovascular collapse as the severe manifestations of cerebellar stroke. So after detailed examination of the patient with cerebellar stroke, go with the CT brain to identify the area of hemorrhage, less sensitive as the image is hampered by surrounding temporal and occipital bones. CT is not that sensitive. MRI angio are more sensitive. Demarcate the area of infarct and identify the site of vascular obstruction. Okay. The treatment includes the same method of any stroke management. Thrombolysis treatment, if presence earlier than 4 to 5 years of onset. Thrombectomy of large vessel disease. Treatment of raised intracranial tension. treatment with antiplatelet agents to continue, and treatment of comorbidities. So this is all about the cerebellar stroke. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, bye-bye. Thank you very much once again.